Just some comments. This will not, this is critical care, so it's not going to be as pretty as yesterday's presentation with, with regard to pictures and stuff. There's a lot of information to just get through it, and I'm free. This is the last lecture of the day. Free to answer any questions. What is important, if you guys get the SCORE curriculum, we're doing organ failure right now, and so this will include all the core stuff on organ failure, but it doesn't have it doesn't include electrolytes and acid and base questions. You just have to really go through those. That's a whole separate lecture. I have a separate 80 slides for that. And so you'll get at least 10 questions on that stuff. So you just have to go through to make sure you know your electrolytes, all the things with regard to, electrolyte deficiencies or too much electrolytes, and acid and base questions, your delta-delta equation, all that kind of stuff, in order to see some of the questions. You saw some of the questions on the SCORE, so and the equations for sodium and things like that. So this doesn't include that because it's just too much information. So anyway, let's go ahead and get started. There's a lot of stuff here. I'll just plow through it. When I give this lecture, I only get through like 10 slides normally because there's a lot of Socratic questions in a lecture like this, but not today. So feel free to ask questions at the end. So just an overview. We'll talk about all these subjects there. And you get a copy of the slides, of course. When someone gets admitted to the ICU, it could be either for respiratory failure, cardiovascular failure, all the different things that can cause it, decrease in mental status, hemorrhage, or potential bleed, for like trauma patients or patients with head injuries, significant comorbid conditions if they had big long surgery. And we admit patients that are for vascular watches, looking for neurologic and vascular parameters every hour or so. So respiratory dysfunction. So usually if you have symptoms of respiratory problems, you have shortness of breath, tachypnea, decreased O2 saturation, decreased mental status, tachycardia, cyanosis, apnea, all the things using of your accessory muscles, fever. In the middle of the night that if someone calls and says the patient's having difficulty with their oxygenation, you go see the patient. Causes could be, especially for surgical patients, could be atelectasis from pain and narcotics, could be aspiration, pneumonia, pulmonary embolism, pneumothorax, hemothorax, fan embolism. Could be getting as bad if someone's septic, the ARDS, and the other things that you see there, which you all should know something about. Discuss some of those topics. So hypoxia obviously is a decrease in FiO2. You could have that just from, these are 5 ways you can get hypoxia. You could be at altitude in a vacuum. You can get hypoxia from decreased ventilation, but that takes a lot of decrease in ventilation to finally make you hypoxic. So that's not always the primary reason. You can have a ventilation perfusion mismatch, which means that you're ventilating part of the lung, or you're not ventilating. Most of the time, you're not ventilating part of the lung because there's atelectasis, pulmonary contusion, ARDS, filled with inflammatory fluid, but the blood supply is going through. So now the blood supply that used to get oxygen is not. So now there's a mismatch, which causes a pulmonary shunt. So ventilation perfusion mismatch is really like a pulmonary shunt. You can also have a cardiac shunt, which would obviously let blood get through that doesn't get oxygenated. And it takes a long time for someone with really primary disease to have diffusion abnormality. Your red blood cell gets oxygenated when it goes just 20% of the way through a capillary. So it takes a lot of diffusion abnormality to cause a diffusion abnormality. Maybe people who recover from severe ARDS have a chronic diffusion abnormality, and that's why they have chronic symptoms. So with decreased ventilation, of course, our patients are part of that, having anesthesia, narcotics, decreased lung volume, give you atelectasis, where the lung doesn't ventilate and sticks together. You could have a pneumothorax, would give you decreased ventilation, a hemothorax. Post-lung resection, you'd have decreased ventilation. Of course, the treatment is improved ventilatory effort. Remove any kind of pleural air or fluid that might be decreasing the ventilation in that lung. You want to decrease your sedatives and narcotics, encourage incentive spirometry and things like that. Sometimes you just need to intubate somebody if they have like with filled chest, which we saw yesterday. So ventilation perfusion mismatch is, again, perfusion to non-ventilated alveoli. It's usually not the reverse. Obviously, the reverse is a pulmonary embolism, and that would be the other, which, would usually, in our cases, might cause a severe ventilation perfusion mismatch. Commonly, it's from alveolar collapse. You can have pulmonary edema. You can have, again, a pulmonary contusion, inflammatory exudates, which happens in ARDS, and pneumonia with pus in the airways. You can mucus plugging, which would obviously make that a mismatch. You can also have ventilation non-perfused alveoli, which again we talked about with pulmonary emboli and fat emboli, which causes a pulmonary shunt. This is the alveolar gas equation. It's always something good to know. You can see how we get to the number of what our oxygenation should be at 100. When you have your FiO2 times your atmosphere minus the water pressure of water vapor, and then minus your respiratory quotient, which is your PaCO2 over 0.8, and you can see how the numbers work out there. But this will lead you to figuring out your PF ratio. And then the diffusing, the normal shunt is about 10%. You can see that it can be considered normal to about 25. After that, it's severely abnormal. So if your PaO2, P large AO2 is 100, your P small A2 is probably going to be around 90, 88, and that's a normal shunt. If you get down to 75 on room air, then you probably have some kind of abnormality. An oxygen content equation is your 1 point. You can see the equation there. Obviously, hemoglobin is the big carrier for oxygen. The amount of oxygen you have dissolved in your blood, your PaO2, is just a small amount. Only if you are put into hyperbaric chamber would that number be increased to a great degree. Otherwise, hemoglobin is the driver of your oxygen. You can also see the venous content there. Obviously, the SpO2, the normal SpO2 is around 70 to 75%. So if you get an SpO2, that's what it should be. If it's lower, that means that the cells are hungry for oxygen. They're taking a lot of oxygen off. That usually means a low flow state. If it's higher, that's usually somebody with sepsis. So the carriers are going by and there's no oxygen being taken off. And so that's about that state. And maybe people who have cirrhosis and liver failure, you can see higher SpO2s. Most of the time you see lower ones, which usually should drive you to say, well, if my SpO2 is low, I should deliver more oxygen. The way you deliver more oxygen, look at your oxygen content. It's time cardiac output with oxygen delivery. I think it might be on the next one. Anyway, you can increase your cardiac output. The only things you really can do, increase your cardiac output or increase your hemoglobin. Obviously, with hemoglobin, we try and keep with the only transfusing people if it's above 7 or lower than 7. However, in desperate times, if someone really needs the oxygen content, their SpO2 is low, I will transfuse them up to 8 or 9, at 8 or 9 if someone really is in need of some oxygen. Most of the time, what you're trying to do is increase cardiac output. So the treatment for a VQ mismatch is oxygen. You can decrease atelectasis, you get your IS, you encourage deep breathing. If you're on a ventilator, you can increase the PEEP. If you have pulmonary edema, you want to give diuretics. If you have airway obstruction, obvious suction. Maybe if you're on a ventilator again, you can do a bronch. If you have pneumonia, you treat them with antibiotics. For ARDS, which we'll get into more detail, you can do the maneuvers there. And of course, for pulmonary embolism, anticoagulation. Sometimes you can do an embolectomy, which they can do down in VIR. You can also use a catheter thrombolysis, which your vascular surgeons or perhaps your cardiologists will do, or maybe IR. Different things you can do for a massive pulmonary embolism that's really causing some problems with VQ mismatch, but usually those patients that have a massive one that are still alive have core pulmonale and right heart failure, and you want to decrease that desperate situation. So ARDS, the term was introduced in 1968. Before that, they were first seeing this in places like the Vietnam War. They call it Da Nang Lang. The reason why they hadn't seen it before and led to the diet is because patients that usually got this were in shock, and this was a post-shock pulmonary failure. And most of the patients just died. They never were able to reach the hospital, especially people with hemorrhagic shock in the wards, to get this entity. This is basically post-shock pulmonary failure. You get hypoxia, diffuse infiltrates, and it's a non-cardiogenic pulmonary edema. It's usually in response to a precipitating event. Could be probably the primary cause is sepsis, so you go trauma, pulmonary contusion. Actually, those are 1 and 2, sepsis and trauma. Trauma can cause pulmonary contusion, or we're talking more about trauma shock. You can have aspiration. So ARDS is kind of funny. You can have a direct problem with the lung itself that causes an ARDS, or you can have a remote cause like sepsis or pancreatitis that causes ARDS. Here's that alveolar gas equation just to introduce your PF ratio. So your PF ratio, if it's above 300, so that's, you can get that calculating with your alveolar gas equation. If it's above 300, that's considered normal. If we put you on 100% oxygen right now, your PaO2 would probably be about 500 to 650. So we give you leeway all the way down to 300. If it's less than 300, it's mild. If it's less than 200, it's moderate. If it's less than 100, it's severe ARDS. Those are the Berlin criteria. The treatment is to maintain the patient, maintain their oxygenation, minimize lung damage, and of course, the primary answer to the question, how do you treat ARDS, is to treat the underlying cause. How do you maintain them though, and take care of the hypoxemia? So first thing you can do is increase their O2. We know that after you get 60%, there were some old studies with the canine model that showed that keeping a subject on a high oxygen for a long period of time, like 100%, you could get some lung damage. You know, with all the people that we've had with COVID and things like that, I think that's probably emphasize the O2. However, we do try and we put it up as much as you need in order to get a PaO2 of 60 or 90%. That's where your hemoglobin curve will come out. About 60 is about 90%. And then do some other maneuvers which are coming up that you would do to try and get your O2 down. So the next maneuver is to increase your PEEP. This keeps your alveoli open. It keeps them from collapsing, and it may recruit some other alveoli that are already collapsed or full of fluid, and then increase your oxygenation. If that doesn't work, the next thing we try is to reverse your IE ratio. Normally ventilators are set at 1 to 2, so your inspiration is 1/3 of the time, and then your expiration is 2/3 of the time. So then we start going to 1 to 1, 2 to 1, 3 to 1. If you think about it, all you're doing is keeping your alveoli open longer so that the oxygen can hang out longer, and then hopefully get into your body. So that's the idea of that. If that's not working, or certainly sooner than most, especially with these patients that ARDS was unusual lately, because I think we treat shock better, we treat sepsis earlier, but now with COVID, we've seen a tremendous amount of ARDS come back. And so prone positioning is used in the armamentarium early. It used to be something you use at the end when some of the other maneuvers won't do it. Everyone gets prone now, and it really works. You put someone on that. The thing about ARDS, it's not, they used to think it was a diffuse pulmonary problem, but it's also depending on gravity. So the worst parts of the lungs where you have your VQ mismatch and your collapse of the lung is according to gravity. So if you're laying on your back all the time, you have the collapsed lung and the fluid-filled lung towards the bottom, towards your back. Of course, your blood supply is sorted by gravity too, and so most of the blood is going down towards your back and towards the lower parts of your lung. And so if you turn someone and you'll see on a CT scan, they didn't notice until they got CT scan, that the upper parts of the lung and the anterior parts of the lung are nice and open. So your VQ mismatch, you can correct it if you turn someone on their front and now you have all the oxygen-aided areas are now getting the blood supply. So about 90% of the time, you'll see a dramatic change on people if you put in a prone position. You can't leave them there forever because of various different reasons of the body. So with these COVID patients, we've been doing about 16-8. So 2/3 of the time they're on their stomach and 1/3 of the time they're on their back. Things get really bad, you can use ECMO. It used to be that ARDS and ECMO really didn't make it much better. I think that's because a lot of people that had ARDS were sent to ECMO late. If you have a center that uses ECMO or a good transfer thing, use the ECMO early. They actually found this out with swine flu, COVID-1, I guess, so to speak, SARS-1. And so we've had certainly people put on ECMOs for SARS too, but with varying results. In the meantime, we found out through major studies that you want to minimize the lung damage so patients have a chance to recover. So we go for the low tidal volumes, which is 6 cc's per kilogram. Sometimes, and when you're in the trenches and you're fighting out in the trenches, you get as low as 4 cc's per kilogram. This will make your CO2 probably go up, but we allow permissive hypercapnia. And it's okay if you have a pH of 7.15 in a normal healthy person. If someone with heart disease, or you're worried about, or if they're on pressors and you're worried about the cardiac instability, or if they have, or if the pressor is not working at an acidotic environment, you can go down to 7.2. Of course, you can give them some bicarb when you're fighting in the trenches and you have to replace some of this stuff. You can go that route just to get their pH at a right level where the pressors will work. And if you want to minimize fluids, but you have to this is organ failure. So as most organ failures, a lot of time they go into organ failures because of decreased perfusion. So you have to make sure the perfusion is reversed first. The shock is reversed before you start minimizing fluid. You can't treat these patients dry when they haven't been resuscitated. They need to be resuscitated first for them to have any kind of shot. So for pulmonary embolism, of course, we give DVT Prophylaxis. I have another slide on that later. Sub-Q heparin. So we use low molecular weight heparin for patients who are multi-trauma, 30 milligrams twice a day for cancer patients. They should also be on low molecular weight heparin. Most of the hospitals will have protocols now. We'll give them 40 milligrams once a day. Patients who are in the ICU should be ideally be on Lovenox. Sick patients, you can see there. COVID patients, now some places will be really aggressive and give treatment doses of low molecular weight heparin. I kind of go halfway, giving 0.5 milligram per kilogram twice a day, because we've seen some bleeding problems of being too over aggressive. Of course, if you get a pulmonary embolism, you want to treat them with heparin, low molecular weight heparin. Anticoagulation will last for garden variety pulmonary embolism for 6 months. If it has to do with a hypercoagulability state, be longer. And then I mentioned about using embolectomies if the patient is very symptomatic with right heart failure. Of course, the classic question you're going to see is that they will have a decrease in their oxygenation and tachypnea, but they always it was just on the score question that came out on the twist question just last week that they also will have tachycardia. So look for that. If a patient doesn't have tachycardia, then you probably in the question they probably don't have a pulmonary embolism. Of course, if you get a hypoxemia in the patient and they're post-op and you don't have to have tachycardia for pulmonary embolism. You can always get your CTA. CTA will only show 80% of the pulmonary embolisms. It'll show the big ones. VQ scan is sensitive, maybe a little bit oversensitive, but hardly anyone gets it anymore. Only if they are contraindicated getting CTA and they're not that sick. And then sometimes you can make a backhanded diagnosis by getting your ultrasound of your veins. For mechanical ventilation, we have CMV, which you really only see in the operating room now. Obviously, the patient's under general anesthesia and they totally control your ventilation. We used to use SIMV on our patients to wean them, where basically you set a rate and you give them some sort of pressure support if they breathe a little bit faster than that. but they will definitely at least bleed the rate. So now, most of the time, patients who are getting full support are on assist control, which means that if they initiate a breath, the ventilator will kick in and give them full support. All they have to do is have the sensitivity set at a very low number so that they will initiate the event. Of course, if they're totally out of it and apneic, if you set a rate, the ventilator will give that rate. They don't have to initiate it. But otherwise, every time they initiate a breath, they'll get the full volume. Pressure control is something that we'll use if a patient has very high peak pressures and you're worried about the effects of the peak pressures on their airways and their lungs. Remember, we try and decrease the amount of damage we give by pressure. Or if you're worried about barrel trauma or something like that, you can put them on pressure control. You'll end up you end up being on getting a tidal volume that won't kind of match what tidal volume you set in their pressure. You have to set the pressure lower. It works. It works on a patient. You set the pressure and they get a certain tidal volume. If you want a certain tidal volume, you're trying to get their CO2 down, you're still trying to oxygenate them, you can turn the pressure up. If they're doing fine and they're starting to wean off pressure control, you can turn the pressure down. So these are used for patients that have really bad compliance and stiff lungs, and you're worried about barrel trauma. This might increase your permissive hypercapnia, but again, that's okay if your pH is normal and you have maneuvers to try and help you with your pH. Pressure support is a weaning mode, sort of. When a patient is awake or waking up and they're initiating all their breaths, they're not apneic. You can't certainly use it on someone that has high narcotic level and is not breathing. You give them pressure support, and basically, when they initiate a breath, they get the amount of pressure that you want. What pressure do you set it at? Well, you set it at a pressure that will give the tidal volume you want. Let's say you had someone who's getting a tidal volume of 500. So you want at least maybe 400, 450. So when you switch into pressure support, you start with a number, 12, 20, whatever, and see what kind of tidal volume they get. So you're kind of matching what they got when they were on AC. And as they get awake, as they get stronger, you start lowering the pressure support until you get to somewhere where you feel like you could extubate them, which usually is about 5 to 10, depending on the size of the endotracheal tube and the size of the patient. It's a good weaning mode. When you are weaning, lots of people will use pressure support as a weaning mode. There's also something called volume support, which is a little bit hard to explain. It's kind of just the opposite of you said of volume, and the amount of pressure they need to get that volume is volume support. Not many people use it too much unless they like it for some reason. Another way of weaning is to give TPs trials. Instead, when you get sedation vacations, usually protocol in many ICUs is to do it in the middle of the night, around 4 o'clock or so. They shut off all the sedation on patients, except your head trauma patients, and then they'll see if they can put them on TPs. And if they tolerate TPs for a half hour or 15 minutes, whatever your trial says, that those patients should be ready to extubate. So it's another way of looking at a way of weaning on a ventilator. We personally like the pressure support method. You must have good respiratory drive, obviously, and those are weaning parameters down there. There's a lot of old-fashioned ones in there. I still use some of those. Everyone should know the rapid shallow breathing index, which is your respiratory rate over tidal volume, which is in liters. And if you have below 80, you have a 95% chance of remaining extubated. If you're above 105, you have a 95% chance of failure. If you're between, you can toss your coin up. But I think it's good to you could have someone with a normal rapid shallow breathing index and have no mental status, and so you need someone over a Glasgow-Coma scale of 8 at least, right? Probably a little bit higher if you're going to extubate them. So those patients are not appropriate for extubation. So you need your good mental status too. And I think to find someone's mental status, you ask them to take a deep breath when they're on their last setting of pressure support, and if they give you a liter or 10 to 15 cc's per kilogram, you feel pretty good about extubating them. So some of these parameters are still viable, whereas the rapid shallow breathing index doesn't necessarily talk much about their mental status. And you'll also see someone with a good rapid shallow breathing index when they're hyperdynamic septic state, but their minute ventilation is so high you wouldn't extubate them because they'll just tire out. So we'll talk about invasive monitoring and those different subjects. So arterial catheters are used for continuous blood pressure monitoring, or and definitely if you're on pressors, or if you need frequent ABGs, basically, is a good reason to have blood pressure, and that radial is preferred. You want to make sure that you do an Allen test. You want to document it, because I have seen patients that have lost half their hand because they don't have a competent arch in their hand, and so you want to make a document that you did it, because people actually can lose half their hand, their thumb and their index finger. And so the map in the radial artery should be the map in your femoral artery, the map in your carotid artery. So that should all be the same. Usually the radial artery will have a much bigger gap between systolic and diastolic, but the map should be the same. Well, A lines are very low infection risk and can stay in indefinitely. And if you do get an infection, you'll see it on the skin. For CVP lines, use them for aggressive resuscitation, or if you need some monitoring, central venous monitoring, for patients who are poor organ perfusion, particularly with people who have pump failure or heart failure. The complications are pneumothorax, more for subclavian, some with an internal jugular infection. Actually, an IJ has the highest risk of infection, mainly because of the way it's on the neck and it's hard to keep it dressed well. But there are obviously one of the safer things to put in, because you usually use an ultrasound. You can get used to using an ultrasound for a subclavian too. You just have to do it. Femoral arteries have the second highest risk, and of course, you worry about a DVT with a femoral artery, but really, the risk of DVT is in the other veins too. Sorry, the veins, because we just don't monitor them that well up on the upper veins. You can get air embolism if you're not careful with how you place them and take them out. You can hit the artery, of course, and you can get some dysrhythmias if the wire goes in and tickles the heart. Most of the time it's self-limited, but you'd be surprised sometimes that it persists. Just a picture of putting it in. I always look for feel that groove right near the end of your clavicle. I know they say 2/3 of the clavicle, but you can feel the little indentation at your clavicle where your pec starts. So that's where you want to aim. You want to go about 2 centimeters behind that and tunnel for your subclavian. And then, of course, if you get used to it, you should use an ultrasound there too. Of course, you know how to do an ultrasound for an IJ. I'm sure you're all pretty confident at that. You don't see pulmonary artery catheters much anymore. Really, the only people that you get to see it now is in cardiac surgery. They still use them. We used to still put them in for people who had pump failure, severe pump failure, or if they have severe organ failure, you make a maneuver, and you give more fluid and it doesn't work. You're kind of like, I wonder what's wrong with this patient. So it's kind of nice to have get this nice swan readings and things like that. You probably need to know a little bit about what they look like on your test, but maybe not. You're not going to see that much. So you can see the complications there. Same for a central line, and then a little bit more for arterial rupture, which happens now and then. The reason why we don't use it anymore, it didn't seem to affect mortality at all with a big study, that having it in or not having it in didn't do much. And if you're putting it in, you can see how the waveforms that you have. First, you'll have it in the vein there, where there's not much of a waveform. Then you'll be in the left ventricle, and then you'll get the top of the PA there, where you start getting a dicrotic notch, and then of course this is a little bit of a wave there. So if you want to do cardiothoracic surgery and doing cardiothoracic surgery, take a look and look how this one goes, because this is probably the only time you'll be able to see it. Postoperative MI, the risk factors are there. Your preoperative evaluation, at the side if a patient needs a stress test or not. Usually they kind of just go over the patient's symptoms, and or if they have a history of heart disease, in order to do a stress test. If they don't have any chest pain or shortness of breath, probably won't get one. Lots of patients of a certain age will get an echocardiogram just to make sure they didn't show any abnormalities that would say they did have an MI at some point or a cardiac problem, and then they might get a stress test. If you're using a perioperative beta blockers, we used to have to use it on anyone who was over 50. They can still be in your armamentarium. You definitely have to continue them. So patients who are on a beta blocker, make sure you continue it post-op. That was a measure that we always had to do. You might also consider someone who's got cardiovascular disease to continue their statin post-op. There is data to show that both beta blockers and statins are good for patients to try and prevent any kind of cardiac problems in the post-operative period. For dysrhythmias, you can have sinus tachycardia. Of course, you always think of hypovolemia, but you can see some of the other things that can cause sinus tachycardia. You don't want to treat the heart rate with the beta blocker if they have hypovolemia, because you're just going to make them hypotensive. So you want to treat the underlying cause, and if you convince yourself that maybe it's SIRS or congestive heart failure and it's not hypovolemia, then maybe you can treat it, because you obviously don't want them to stress out their heart and maybe you get an MI. Particularly if someone is older. For supraventricular tachycardia, it could be that they have adequate perfusion. You have to make sure they have that before you do some treating. And if you can't distinguish it between ventricular tachycardia and supraventricular tachycardia, you can always slow them down. It might break them also with adenosine. You can use 6 milligrams and then repeat that if it doesn't work. Lots of times it might not work. It'll certainly slow them down. You'll get complete heart block with adenosine, which is always a tense moment. But they'll start coming up, and then you can see first they come back as the atrium. So you see the P waves first, and you can see if you have the P waves at the same rate marching through, or if you don't have P waves, and it could be ventricular tachycardia. So for atrial fibrillation, you have to check and make sure they have adequate perfusion. And if they do, then you can consider a cardioversion of someone who's symptomatic and hypotensive. If they're not hypotensive, you'll try and slow their heart rate down. We usually use beta blockers or calcium channel blockers. If someone is hypotensive, you might want to use amiodarone. That would be the choice then, because it would cause less hypotension than a calcium channel blocker or a beta blocker would do. If they're hypovolemic, you have to treat all those causes that you see there. Lots of times, especially in cardiac patients, the patient have thoracic surgery, they get fluid overload, acute fluid overload, because of their output on their heart is backed up after they have a resection, and that's the cause. So then you obviously want to take some of that fluid off. Could go either way. So basically, your cardiac output, your stroke volume is dependent on preload, contractility, afterload, and heart rate. You have congestive heart failure, it's a pump abnormality. Hopefully you have an echo. If you have a patient new to the ICU and they don't have an echo, you probably want to get an echo on everybody. You can also learn how to use your ultrasound and do your own echo, so you can see what kind of heart function they have. Okay. They will need some kind of central monitoring, because you want to maximize your preload. This is where a swan would be really good if someone has a stunned heart that they do after cardiac surgery, or chronic CHF, so you can do a Starling curve, which I have on the next slide, I think. And so you just want to maximize your preload to a point where it increases their cardiac output and reduce their afterload, but to a point you want to maximize their preload until their cardiac output starts going down, and that's your Starling curve. So you can see if you increase your end diastolic volume, your stroke volume goes up, and then you'll get a part where it'll level out, and then if you're getting too much and they start having dysfunction, that means you're too fluid overloaded. Of course, people with varying marks of CHF, their curve will be lower and lower. But even those patients, you have to make sure that the patients who have cardiac failure, you're maximizing their preload. You can't assume that they should be dry as a bone. And so that's where a swan would have been helpful in the past, and that's what we used it for. So you can also look at their cardiac output with the measures of cardiac output we have now. So you can still do a Starling curve, and with your Vallejo, using your arterial line for cardiac outputs, you can increase their preload and see what happens to their cardiac output, so you can still do it without a splint. So shock is inadequate perfusion and oxygen delivery to cells, disrupting the cellular metabolism. That's the official definition. So you can have hypolimic shock for us, a lot of times it's hemorrhagic shock. We talked about some of the stuff yesterday, mostly, and embolisms. Cardiogenic, we've kind of already touched on that. Distributive shock, which is SIRS or sepsis, is the primary. Could be anaphylaxis. It could be neurogenic shock from a cervical spine injury. And then you can have endocrine shock, which could be adrenal insufficiency or thyroid insufficiency. So I had this on a slide from yesterday, but you have a slide of it today for your classifications of hemorrhagic shock. You want to replace your preload. Of course, in trauma patients, we've learned that you don't want to give just 1 to 2 liters. You don't want to give a whole lot more than that if they need blood, and you want to go to blood transfusions early. You should use the same principles for a GI bleeder and such. Now, just to say that, I actually have a slide on that, so I'll wait to that. You might need to initiate your massive transfusion protocol after hemorrhagic shock, and you stop bleeding, and you stop the bleeding, and you've given them enough blood. They still can be in shock from a post-hemorrhagic shock with a distributive shock. They can be massively vasodilated from the amount of time they were in shock or how severe the shock was. They can have a post-distributive shock. That's when you start giving fluid back. So pressures increase the mortality in hemorrhagic shock if the bleed is not controlled. So stop the bleed, right? That's the main thing. This is an experiment that was quoted very much back in the '64. I'll just a quick side. I just want to have them in your set because I don't know if you're going to get questions on this. But the main thing is traumatic shock. You needed blood, but you also needed blood and crystalloid. So you give them blood until you stop the bleeding. Once you stop the bleeding, they don't need blood anymore. Of course, we give them blood, FFP, and platelets. We replace the whole thing, like whole blood. But after that, they could still be in shock from that distributive shock. So then you start giving them crystalloid in that ICU period post-op. They'll end up needing a lot of crystalloid. You don't have to worry about it. That's the way it is. That's the way it'll be. This is the studies that they did, a whole bunch of there that show colloids versus crystalloid in trauma. The bottom line is there was no difference in resuscitation giving colloid or crystalloid, so we end up giving crystalloid, particularly because it is cheaper. Some studies you might, just in case you wonder about hypertonic saline, it's there, the limitations and what we've experimented with. This is also a listing of the hemoglobin-based substitutes we had, which none of them are on the market now. I was involved in the study with the polymerized hemoglobin. Basically, it's pretty safe, but it's hard to give it to patients without their consent. Anyway, just so you can have that reference in case you need it. I don't think you'll see any questions on it. So, obstructive shock, we know about that. Obviously, tension pneumothorax, cardiac tamponade, and the embolisms. And so these are the different things that can cause that. Just be aware if the patient goes into shock from these causes that you always look for in one of those causes. Of course, with cardiogenic shock, you have myocardial infarction, congestive heart failure, post-cardiac surgery where you sort of have a stunned heart, and some valvular disease. For distributive shock, they say, well, you know, they might put in your question that the patient's in shock, but they have warm extremities, and they're trying to make you think of distributive shock. So I don't know if they'll be that kind or not. If the patient has an allergy, it could be anaphylaxis. In a trauma situation, it could be a spinal cord injury. In trauma, just always remember that you always treat someone for hemorrhagic shock until you find another cause. Because if you give volume to patients, it'll make all these shocks better. Even cardiogenic shock, because they need preload, it'll make it better. Even cardiac tamponade, it'll make it better temporarily while you're trying to figure out what the cause of the shock is. Adrenal insufficiency can have 30% of ICU population. If their patient is on chronic steroids, of course, you have to make sure that you give them stress doses for surgery. We do recommend steroids in patients with septic shock. You'll see it later. Right now, the recommendation is only if they're on pressors and you still can't get their blood pressure up. So it's kind of a last thing to put in there. You don't give them early because it does increase infections and probably is not good for someone who has sepsis unless you need it. And so you can check their certificate. I still tend to check cortisol levels, but the answer to the question is you don't check cortisol levels. You give it to patients if they're in shock and they're on pressors and you can't seem to get them out of shock. That's the answer to the question. You don't do a corticotropin stimulation test, but that's what it's there just so you know. I like checking cortisol levels myself. I figure that if it's under 20 and someone who's really sick, they have a problem with putting some steroids out. If it's over 100, then that's really not their problem. But again, the answer to the question is to give steroids if someone has refractory shock that's not being responsive enough to pressors. These are just things that are listed there in case you always see some sort of questions as to what's elevated during shock or during someone who's sick and the metabolic response. So you have all these things there. Not much to say about it. That's just what happens. What do? You know, obviously fluid hydration. If someone is with distributive shock is seeing decreased perfusion to their organs because their blood pressure is down and they're leaky. You watch for hyperglycemia, steroids again. We've gone over some of this stuff. You have to make sure the patient gets early enteral nutrition. The answer to giving an enteral nutrition to someone who's on pressors the first couple of days is probably not to give it to them because you're worried about maybe increasing the shock to their bowel. But otherwise, you're thinking of early nutrition. Immune-enhancing formulas we give to our trauma patients. It's always a good idea in septic patients. And pyruvate can also be added. So this is just looking at your oxygen delivery questions. Remember I said that if you want to increase your oxygen delivery, the only thing you can do is increase their cardiac output or increase their hemoglobin. So if you have a normal extraction ratio, which is your SVO2 your SaO2 minus your SVO2, so you can get an SVO2 in a gas, you get an SVO2 from your central line. A true SVO2, it would be from a pulmonary artery catheter, so you kind of look at that if you want in the cardiac patients. And again, the normal number is around 70 to 75, depending on what your SaO2 is. If it's lower than that, you need more delivery. How do you make more delivery? You give them more cardiac output, or you give them more hemoglobin if the hemoglobin is low. Okay. So this slide kind of answers all that question. We used to have someone that believed it showed that the patients had higher in survival if you gave them super normal delivery. But as we found out, the data wasn't that good, and the patients who couldn't achieve supernormal delivery were taken out of the study. So that's kind of not right. And so only the patients that could achieve it did well. So that kind of makes sense. Anyway, you just want to make sure they have good delivery. So that's how we can check your SVO2. Endpoints of resuscitation, you look at base deficit, lactic acidosis. So we used to have things, I don't know how many centers you guys might be in, some that actually check into mostly pH. So they're looking at the actual organ base deficit and things like that. And you'll see the different companies have these things at the American College of Surgeons or whatever to show that you can look at the actual oxygen delivery to the muscle or your stomach organ. We really don't do that. We kind of just get a general picture, which is what the base deficit does. Base deficit could be related to your lactic acid, especially in trauma, and hemorrhagic shock. It is associated with increased mortality, failure to improve, or clear your lactic acid is a marker for outcome. Other reasons for increased base deficit but not increased lactic acid are hyperchloremic acidosis. Renal failure is obviously a big cause. Usually, if someone has a normal lactate but they have acidosis, this might be something wrong with their kidneys. And you can also get it with intoxication. Just to show you what's out there. So for looking at our pressors, norepinephrine is the alpha agent with some beta activity. It'll do those changes. It's the most studied pressor in septic shock, and it is the recommended for surviving sepsis, the pressor of choice. Lots of times the patient will come out of the OR with neosynephrine. You want to take that off if they have sepsis or they need a little bit of kick of their heart. You want to get it switched to levofed because neosynephrine is a pure alpha agent. But they love it in the OR. It gives them a little kick right away. You can get a reflex bradycardia. So if you're on neo and you have a spinal cord, cervical spinal cord injury, you can actually, I've seen patients actually get heart block from that because they already have the chance of getting bradycardia from their spinal cord injury, and it can block you. We do use neosynephrine. It's a great drug for patients with head trauma, trying to increase their cerebral perfusion pressure, because it doesn't cross the blood-brain barrier. So you can say that 3 times fast. So that is probably the only instance where I make it the judge of choice. Epinephrine is your third-line drug in septic shock. Certainly one of your first-line drugs in post CPR or for patients that come from cardiac surgery. And of course, obviously, use it in ACLS. Just get comfortable with you should always be comfortable with the dosing. Vasopressin is your second-line drug for septic shock. It's your second-line drug really in all kinds of shock now. Interesting enough, patients who are septic shock have decreased vasopressin levels, and so it makes sense to give vasopressin. You're kind of giving it back. Dopamine on low dose dopamine is on dopamine receptors are in the kidney too. That's why they used to give it to people thinking that it was kidney protective. It actually is a diuretic like Lasix, and that's why people had a higher urine output. It might not actually help their perfusion though, if it's acting like a diuretic. Anyway, you get tachycardia with dopamine. So this is a good drug for people who have spinal cord injuries, because if they're very bradycardic or someone has bradycardic type arrest and they remain bradycardiac, this would be a drug that you could think of that instead of normally going to norepinephrine. Dobutamine has great beta activity. The problem is they get a reflex tachycardia, and it's also a vasodilator, so it might not increase their blood pressure. You just have to test it out basically, and that's where a swan might help. But you don't necessarily need the swan. You can test it out by seeing what happens when you give it, and if their blood pressure drops, maybe it's not the right choice. Milrinone is a phosphodiesterase inhibitor. It's a good inotrope, and it's good for patients who might have pulmonary hypertension. And so if someone's in bad heart failure and I really want to use an inotrope, I'll probably reach for this one. Great to look at when you do have a swan. You can actually increase someone's PaO2 with it if they're in bad ARDS. I don't think it's used enough. And you won't get the systemic vasodilation that dobutamine gives you. For acute renal failure, mortality is about 50%, maybe even higher. Most renal function is related first to pre-renal hypovolemia. Sepsis is the leading cause of ATN, but other toxins can contribute. IV contrast, antibiotics, rhabdomyolysis, transfusion reactions, things that you guys will see. Vasopressors. My radiologist says we worry too much about IV contrast causing renal problems. If you're worried about someone that they have an SMA occlusion, you really need to know. So I wouldn't worry about their kidneys at that point if you're worried about other things. So anyway, you always look for post-renal obstruction. Make sure the Foley's flushed if their urine output's down. And there's the FENA equation there. You'll need to know that. That'll be on your test guaranteed. And if it's less than 1%, it's pre-renal. If it's greater than 2%, it could be ATN, or it is ATN. There might also, I saw in the score questions recently, twist questions, that they have those muddy brown casts. That's for ATN. If you see eosinophilia, that's acute nephritis. And I guess I'm trying to think of some other ones. Those are, I think, some of the ones that they mentioned in the equation. Actually enough, I didn't particularly know this until I looked it up last night. If you're over 4%, that could be renal obstruction. This is your rifle criteria. There was a question on this in TWIST. So just be aware of it. It's rifle. You can see the reason why it's rifle, or risk, injury, failure, loss. Yeah. And so I think the bottom two really don't matter that much. You just want, if you're going to call someone whose creatinine is getting worse, those are criteria there, the GFR, their increased creatinine. And so if it's 1.5, it's risk, 2, it's injury, 3, it's failure. So that you can make a diagnosis. You should be aware of this, because it wasn't a question on Twist. So renal dysfunction, address your drugs. You always have to address your drugs. Sometimes you see that in a question. Antibiotics, things like that. You have to make sure you don't have drugs that might cause increase, like NSAIDs. You'll see something like that. If patient getting Toradol, if they're elderly, they have primary renal disease, maybe you shouldn't give them Toradol. It also can increase GI bleeding. Dialysis is indicated for these reasons. Only if you have trouble with fluid management, someone's getting way fluid overloaded, it's affecting their oxygenation, and they need urgent dialysis. Electrolyte abnormalities, mainly potassium. If they're hyperkalemic, that was also on the Twist recently. And acidosis, you can kind of compensate for that with bicarb initially, but eventually they might need it for acidosis, or if they're severely uremic, which would be, and severely uremic is well over 100, about 150. Uremia will also increase their coagulopathy, and you treat that with DDAVP. So CVVHD is better for patients who are hemodynamically unstable, because you can take just a little bit amount, take a little bit more. When they have dialysis, they end up taking a couple liters off at one time, and so it's not that good for patients who are hemodynamically unstable. I think it does have an added effect of removing inflammatory mediators, so I think it's good for people with renal failure who are septic. Certainly, we've seen a lot of CVHD used for COVID patients. Just hepatic failure, because I could kind of remember it's kind of nebulous. What causes hepatic failure? Well, I think that some people who might get all these things had some pre-hepatic failure, so you should understand the complications of cirrhosis. Of course, just like any organ, if you have shock, you can get shock liver. You usually see a giant leap in your enzymes first. It would show that you had some decreased perfusion to your liver. And then all these are complications of cirrhosis. You have malignant ascites, not malignant ascites, but bad ascites that's causing a lot of pressure or a lot of fluid shifts. You can tap patient. You usually replace it with IV albumin. You want to avoid a lot of salt because it'll just go into the ascites and increase the amount of fluid. People who have bad ascites can get hepatorenal syndrome. Once you start getting hepatorenal syndrome, those patients are in real big trouble. And the FeNA if someone's hepatorenal, usually shows a FeNA less than 1%, very low urine sodium. And of course, their kidneys are normal, but they're seeing just a decreased perfusion, so that's why they're dry. It's hard to get fluid to them because you put fluid into these patients and it goes into their ascites. If a patient gets encephalopathic, you can check their ammonia level. Might correlate, might not. You think about encephalopathy, if someone all of a sudden gets encephalopathic, it's usually because of some cause, and that could be primarily sepsis or a GI bleed. Of course, liver patients could be coagulopathic, and you can see a TIPS there. Usually that TIPS distance is about 1 centimeter, the diameter. It could be 0.8 millimeters. They kind of adjust the width of the stent depending on how much shunt they need, which is basically a portal cable shunt and done via the internal jugular vein. Use TIPS for someone who has bleeding varices, ascites, and portal vein thrombosis. We had a patient like that, and they used the TIPS, and it kind of helped with the superior mesenteric vein thrombosis. Again, kind of repetitive DVT prophylaxis. Most patients get 5,000 units of heparin sub-Q TID. Patients who are sicker or cancer, they should get Lovenox. Common patients get Lovenox BID. And then for our COVID patients, This is what I use. Some of them are, if they have really, really high D-dimers, some of the pulmonologists will put them on full dose treatment, which is 1 milligram per kilogram twice a day, or 1.5 milligrams once a day. They can get huge whopping doses with that, and I've seen some bleeding complications, so I don't know about that. HIT, you want to stop the heparin. You can see the scoring here for HIT right there. Mainly the one to remember is a decrease at 50% all of a sudden in your platelet count. You want to use a direct thrombin inhibitor if you need to use it IV, or Gatroban or Fundoparinox is a direct factor 10A inhibitor. It does not affect the platelets. And you can send your antibody for LISA. Your LISA test could be positive. You want to confirm it with a serotonin test, because 86% of the patients that have a positive LISA have a negative serotonin test, and they don't have HIT. So they need the confirmatory test. Obviously, you keep the heparin off it if it's a positive LISA while you're waiting. GI gastric prophylaxis, either H2 blockers or PPIs. H2 blockers is getting a bad name. I guess PPIs too a little bit, because the infectious disease guys don't like them because it gives you a higher chance of C. diff. Those people who weren't getting antibiotics, what caused C. diff here? You should give it with someone on mechanic ventilation, but if they're getting fed, you stop them. You don't need to give GI prophylaxis for someone who's getting tube feeds or eating. Really don't need to give it to anyone upstairs either. You just need to give it to people in the ICU, unless they're chronically on this stuff, or if they're on those other things on the bottom, steroids, NSAIDs. I might think about giving it to them. So enteral feeding is much better than TPN. Again, I caution you, maybe you get a question that says, someone's on 3 pressors and should you start enteral feeding? Maybe you wait until they're not in severe shock, because you might be giving their gut a stress and they can go into dead gut, which is the theory. If someone comes up and says, how much calories you want to give, you should know this. You should know. I know now we just say, let me look at the dietitian's note. Well, you guys should know what to give them to start off with. And so you want 25 to 30 kcals per kilogram. And the 1 to 2 to 2 grams of protein. You notice when I had the burn question yesterday, they get 2 grams of protein per kilogram in a hypermetabolic state. You can't change, that might be a question, you can't change the negative protein balance for someone who's under stress. However, you can give them some replacement, which is what you're doing, and that's why it's good to start nutrition. You'll never find any data that shows you nutrition decreases mortality. You just can't find it, but we all assume it does. And you're counterbalancing the stress that they're in. So 2 grams for burn patients, trauma patients, 1.5 to 2 grams for head injured patients and stuff. And then normally you give about 1 to 1.2 grams of protein per kilogram for someone who's not in stress. You can use a metabolic cart if you want to measure it. We used to do UUNs. I guess we don't do it anymore. It was kind of fun. You just see how much nitrogen they're putting out, and you figure out how much nitrogen you need to give them in order to balance that out. And you start as early as you can, except one exception being someone who's in severe shock for a day or 2. Hyperglycemia is common in the ICU. We know it leads to infections. It leads to mortality. That's why ICUs are really interested in having a protocol to keep their hyperglycemia down. You want to make sure you avoid hypoglycemia with your protocol. Insulin drip would be recommended in the ICU to have a better control of your sugars. But as patients getting better, you obviously don't want them having insulin drip. And that doesn't mean that you don't give them more long-term type ICU. I can't give you a whole glucose lecture. That's not what this is about. But you should be familiar with how much insulin you use. Hypoglycemia and refractory, remember this, hypoglycemia refractory hypotension is a sign of adrenal insufficiency. If you have someone who's sick and they're hypoglycemic, and it's not from a big shot of insulin they got, they have adrenal insufficiency. So Blood transfusions are good for people who need blood, but they're not so good in general. They have an immunodepressive effect. You'll always hear studies on everyone that blood transfusions increases is an independent risk factor for morbidity and mortality. Of course, what came first, the fact that they needed the blood or not. So, but that you'll see that said. And that's the reason why we wait to give a transfusion trigger of 7 as opposed to 10 in the old days. And that was a trial study. If a patient's severely sick, like I said, they need that oxygen delivery. Sometimes I'll shoot for 8, or if they're going to go to the OR, you give them a little cushion. You shoot for 8, knowing that they're going to lose it. Ventilator-associated pneumonia. What's causing it? If it's less than 72 hours, it's probably one of those 3 organisms. If it's over 72 hours, it's something that's in your hospital or an opportunistic organism. So it'll lead you to what you should choose for antibiotics. Because infiltrates, high fevers, high white counts, infected sputum. If you're in a center that does Bronx and gets a quantitative culture, you go 1 in 100,000. Will show you that you actually have pneumonia as opposed to just infected sputum in your trachea. If you are going to treat for ventilator-associated pneumonia, give them big guns. 35% higher mortality if you guess wrong with your antibiotics. So you want to start big and you de-escalate. Zosin's a good drug. At Stanford we call it Killer Z. So you start with something big, and then you de-escalate. And then preventative measures there: wash the mouth, head a bed up, good pulmonary toilet. They have the slurry that they use to decontaminate the bacteria that's in your stomach now because you're giving them antacids and things like that. UTIs, common cause of sepsis in the elderly. Of course, you can get it in the ICU. If we get it in the ICU, the government won't pay your hospital any money, so the hospital is going to get mad at you for letting someone get a UTI. And so we just don't send urines for cultures anymore. But what you do want to do is get rid of your catheter early. I'm sure that a lot of hospitals have nurse protocols that they can get rid of the catheter if the patient doesn't need it. You don't want eclampsia either, central line associated blood infection. Lots of times it's gram-positive. It's most common in internal jugular. Of course, a lot of lines are in internal jugular now because of the ease of putting them in with ultrasound. You want to be obviously really strict on putting a central line in sterilely. They're really strict when they change the dressing. Always use, I don't think any hospital would not use an antibiotic-coated catheter because they can last 10 to 14 days. And we tend to leave lines in longer, and really at 14 days, you really should consider something earlier too, getting a PICC line in. Of course, yeast infections could come mainly with patients with TPN. Wound infections, you want aggressive debridement. Abdominal infections, you need source control. I threw Clostridium difficile, not that it's an abdominal infection, but it's in your gut. Comes from antibiotics, maybe H2 blockers. Now, almost everyone's treated with PO vancomycin because they're worried about flagell not working on some of the more resistant Clostridial infections. But if you can't give PO for whatever reason, you can still use IV flagell. There's a lot of other maneuvers about putting stool down the NG tube and all kinds of stuff. Obviously, you want to look. This should be in a separate lecture when you look at your colon stuff. If you want to make sure someone's not getting too sick and might need a colectomy. Always think of acute acalculous cholecystitis, and you might need an ultrasound in someone trying to figure out a fever in the ICU. So for sepsis, you could have fever, hypothermia, source of infection. You're probably looking for postoperative patients, preoperative patients if they came in with an infection, common in elderly population, all those things there that you can see. The SIRS criteria. If you can have SIRS without sepsis, people with pancreatitis have SIRS. But if you have documented infection of sepsis, severe sepsis, organ dysfunction, you still will see some of this. I know there's different things, which are on my next slide, to quantify sepsis or not. Anyway, you might still see this, or severe sepsis, organ dysfunction, lactic acidosis, and septic shock, of course, is hypotension. Some more, this is your SIRS criteria and more modern definitions that they have. This is the severe sepsis, organ dysfunction. So if you have a creatinine above 2, and it's a change for that patient, sort of a acute kidney injury, that's organ dysfunction. You can see the different things there. So if you have any of those, then you can call it severe sepsis. That's the way to look clinically. You can have a leukocytosis, a C-reactive protein will be up. You can have signs again of severe sepsis. For the SOFA score, which is what they use now, they measure all this stuff. I have the score in the next slide if you want to see it. There it is. Just so you have it there. We have the abbreviated SOFA score, which is very simple right there. And you can say someone could be in sepsis if they have an infection, of course, if they're greater than 2. So you just need 2 of those. It's controversial, obviously, but it's better than, if they think it's a better score than SIRS. It predicts mortality if it's less than 2, 3%, if it's greater than 2, 24%. Greater to or equal to 2. That's what that line is for. It's not very good. So you just see some document facts about sepsis. And of course, we have surviving sepsis. The last time it was updated was 2016. We want to early recognize severe sepsis, give them antibiotics, get their blood cultures, give them antibiotics within the first hour. We want aggressive fluid resuscitation, which is 30 cc's per kilogram within the first 3 hours. You want to check the lactic acid, and you want to repeat it at 6 hours. If they're fully fluid resuscitated, then you start your pressors. Of course, we start, as we said before, norepinephrine, then vasopressin, then epinephrine. Then whatever else you can give methylene blue for someone who's in sepsis. Anyway, vitamin C is big out there. Keep that in mind. You might see a vitamin C question about giving that for someone who's in septic shock. Steroids are for refractory hypotension. So this is just an algorithm that follows the severe sepsis guidelines. So you have that. You can always peruse that. These are the difference between the second recommendation came down in 2012. I think the first one in 2008. So we'll probably see something coming up soon. 2016 there. You can see the differences they made. And then that's it.
Awesome. Thanks, Dr. Dwyer. Quick question from the audience. The question is neosynephrine versus levo as the preferred drug for neurogenic shock.
Yeah, I prefer neo for the reasons I said. Oh, for neurogenic.
Spinal.
So spinal shock. Just be careful. You can use neo. You tend to use it because it's a common thing to use in the neurosurgery ICUs. But it can cause severe bradycardia, and I've seen people actually go asystolic with it. Very rare, but they've done it. And so sometimes you think of dopamine. If the brady, answer is I would probably use neo still, but if bradycardia is an issue, Levoped's probably fine. You can use Levoped. It doesn't hurt people who are in neurogenic shock.
Just for clarification for everybody, neosynephrine is phenylephrine on the boards.
Right. So Levoped is fine for people who are in neurogenic shock.
Awesome. Okay. Well, thank you for doing 2 back-to-back lectures. That was awesome. They're very, obviously, in-depth topics. Thank you so much. And
yeah, no problem. My pleasure. I sent it to you. Did you get it?
Yes, I got it. Yep. So all the PowerPoints from all the lectures are currently on the Google Drive, as well as day 1. So yesterday's lectures are all there via links. There's other PowerPoints. One is the radiology one that I posted, as well as some hernia lectures by Dr. Daoud. And then Dr. Joel, I can't ever say his last name, is going to come back on and finish up the colorectal questions. There's a couple more things I just wanted to let people know. If anyone is from a program that has interested attendings to present next year, it'll be January 8th and 9th, just shoot me an email with their contact information and we'll get in touch with them. And I'll also send out an email to everyone who signed up the links for the recorded lectures. If there's not any more questions, we will proceed with colorectal questions with Joel. Oh, Elizabeth, can you speak about the role of TAG and ROTEM? These questions are starting to come up on the ABSITE. Dr. Dwyer, are you still on?
Yeah, I'm here.
Okay, great.
What was the question?
Oh, what are the roles of TAG and ROTEM in resuscitation?
For TAG, right?
Yeah.
Okay. Basically, you know, it gives you a good overview of your coagulation. So it's very much looked at for trauma patients. So getting a TAG in the trauma bay, so you can kind of see if they think that if you have a patient that might need coagulation factors, or if you depending on, and so that's your R time and if their maximum amplitude is not right, it's too short, then they might need platelets or fibrinogen, and so it kind of gives you a at the moment idea of what they need, as opposed to sending things to lab and waiting for results back.
Awesome, thank you. I would definitely recommend Googling a photo of the TAG before the ABSITE. It'll definitely be on there.